I want to welcome Dr. Tay Kopanos, the Vice President of State Government Affairs for the American Association of Nurse Practitioners, where she oversees the state advocacy program for AANP. Dr. Kopanos draws from 2 decades of clinical and policy experience to inform workforce and healthcare policy. Under her direction, AANP has successfully overseen the passage of hundreds of state laws in support of NPs and their patients. And on a personal note, Tay is one of the first folks I've met when I started working with NAP, and she helped guide me on state health policy and has been just a wonderful colleague and mentor from the beginning. So Tay, thank you so much for all that you do for nurse practitioners, for those of us in association management and whatnot. We really appreciate your expertise and for you joining us this evening. So thank you. We appreciate you being here, and I will turn it over to you.
Absolutely. And thank you all for coming out tonight to listen to this. And, we have such a great relationship with NAP. I know that you are on these calls all the time with Michelle and you reap her benefits, but she is a phenomenal colleague, as is Dave. We have standing calls. There's not a week that goes by that I don't think that I have a call with folks at NAP to talk about how we can utilize some of our shared resources, our knowledge, and really our voice and power as the nurse practitioner community to improve health for folks everywhere. And so thank you all. You guys have been instrumental in a lot of areas. So when Michelle asked me to get together, I was really excited to come. She asked me just to share a little bit about, kind of policy in general, what we're seeing in various things, and then open a discussion. And in working with nurse practitioner associations around the country, that's where I really find the most value. So my presentation this evening is going to be short to give us some more time to have some conversation. To keep me short, I put together just a short PowerPoint to give us a little bit of background. So let me...
Tay, as you're queuing up your slides, it sounds like your audio might be going in and out just a bit. So I'm not sure if you can be closer to your microphone or.
Yeah, I should be able to do that.
Thank you.
Although I don't know how to make this a slideshow because it's not showing, but you guys will just get to see the peak and see where we're going. So happy New Year to everyone. On New Year's Day, Governor Charlie Baker signed into law full practice authority for our colleagues in Massachusetts. This is a huge win. For those of you who follow the AANP map, you know that Massachusetts stood out as that red little spot in those New England states. And now we have an entire region, the New England region, that has full practice authority. That makes 2 regions in the country where all the states in those regions have full practice. And Massachusetts, if there's anyone from Massachusetts on this call, the amount of work and the effort and the persistence that they demonstrated really came to fruition. When I first came to AANP in 2010, Massachusetts was looking at, what do we need to do? How can we move things forward? Started some preliminary planning, but this bill really is a culmination of 8 years of really steady and significant work by our colleagues in Massachusetts. And we're going to talk a little bit about, what are some of the core principles? How were they successful? What kind of things can we learn from them and export? But I also want to note that their victory really belongs to the NP community at large. Elements that they utilized in their campaign were things that we picked up from Texas, a deeply red state where the physician community really weights the scale there. And the physician community about 8 years ago in Texas started putting out some language about the preparation of nurse practitioners and compared and contrasted it to physicians. And because of some of the message points that were being vocalized in Texas, at AANP, we took a look at them. We said, what, they're going to export these everywhere. And so we created the AANP Yardstick document that really talks about how the preparation of physicians and nurse practitioners is apples and oranges, and that the yardstick really to compare our 2 disciplines, and the outcomes of care are, truthfully, the outcomes of care. I like to tell folks that my husband and I both go to the same grocery store. We both have different routes that we prefer to get there. I think mine is more direct. He thinks his is more direct. But at the end of the day, despite our 2 different ways to get there, we get to the grocery store, we buy our groceries, and the outcome is the same. And so when we're really looking at education, it is about the outcome and not so much the pathway. And then just a reminder, I know you guys already know this on the call, nurse practitioners practice advanced practice nursing. but the tools and the education that underpin all of healthcare practice, whether you are a nurse practitioner, a physician, a physical therapist, a dentist, that education, like basic pathophysiology, the principles of pharmacokinetics, those belong to everyone. No health discipline owns them. And we're just wanting to be able to bring all those skills, all of that knowledge to our patients in every location. Full practice authority, this map, is really this indicator of where we are on practice authority around the country. And full practice authority isn't just nurse practitioners doing what they want or being able to open businesses. This reflects licensure and individuals' legal authorization to be able to practice their own profession. So in states that are green on the map, nurse practitioners can diagnose, treat, manage, and prescribe for their patients completely on their own authorization under the State Board of Nursing. In states that are yellow, an element of their practice is regulated by a collaborative agreement, or they're restricted from providing a service in a select setting. And in the states that are red, nurse practitioners are required to have a supervision or supervisory or protocol arrangement with a physician to have the legal permission to do their job. So when I explain this to legislators, I like to break it down to concepts that people understand. And I know you guys know it, but I find for legislators, breaking it down to talking about licenses and driver's licenses, everyone understands that you have a driver's license. It's your own personal authorization that the state gave you to drive a vehicle. We don't require that you have a relationship with someone else in your neighborhood or someone who rides a motorcycle or drives a semi-truck to have the legal permission to drive your car. We also don't make you have a permission slip to make left-hand turns. Writing prescriptions would be our analogy there. And we don't make it illegal for you to drive your car and have a license unless you're in a carpool. But in the states that are red and yellow, that's exactly what we do for the licensing of healthcare professionals. And with our driver's license analogy, if we made it illegal for people not to drive unless they were in a carpool, kids wouldn't get picked up, groceries wouldn't be delivered, people couldn't go to work. If we made it so people couldn't make left-hand turns unless they were in a carpool or had a permission slip from someone else, that would create traffic jams and it would roadblock and impede traffic. Because we do the same thing in healthcare delivery, our licensure system is impeding healthcare delivery, diminishing access, and is really contributing to some of the geographic restrictions that we see in people getting access to care, especially in rural areas in the central and south of the United States. So on this New Year's week, we are celebrating Massachusetts. So again, congratulations to everyone and our colleagues in Massachusetts. I'd be glad to answer any questions that you have about full practice authority, what it means, where it's going, and why it's important at the end of the conversation. This last week, we've gotten, probably 30 emails in the last 2 days from states around the country and nurse practitioner organizations saying, tell us what Massachusetts did so we can replicate what they have. And we get that anytime a state passes successful legislation or moves things forward. It's the see one, do one, teach one. How did they get where they got so I can replicate it? And the parts of Massachusetts that I think are really important to take away is Massachusetts was successful because they got a game plan, they stuck to their game plan, they didn't waver in their game plan, and they followed the core elements that are successful for all legislative campaigns. They have been running legislation, like I said, for nearly a decade. They had some really clear guidelines for what they wanted and where they were willing to compromise, and that really helped set them up. So core elements for winning a piece of legislation, whether you're looking at supporting nutrition in school lunches, full practice authority, or signature recognition, AANP, when we look at pieces of legislation, and we do this for every piece of legislation that we've worked on, we do a postmortem on those campaigns. We've started because we found these core elements consistently through all pieces of legislation. We now do a pre-mortem as we're getting ready to deploy AANP resources and work on campaigns. We use this as a checklist to see, hey, is this particular piece of legislation going to be successful? Bills that are successful are engaging in a place where there is a favorable political landscape. Running a campaign is a lot of work. It takes a lot of money, and it's very emotionally intensive for the NPs and the organizations that are running them. So the favorable political landscape analysis, I cannot say that it's not a place that you want to skimp. Knowing what legislators are going to be on what committee, if they are going to move your bill. We have had states that run full practice authority legislation year after year after year, but they have a powerful anesthesiologist that sits on the Health and Human Services Committee that roadblocks them every time. We know when we do that landscape analysis that they're not going to be able to move that bill forward. When we look at other states like Massachusetts, they started running their legislation when the conversation was talking about what do we need to do to expand Medicaid and the ACA and controlling for healthcare costs. So that was one of their messages. This last year, they had the governor who issued an executive order waiving the requirement for collaborative agreement supervisory arrangements, in Massachusetts for NPs after 2 years of practice as part of their COVID response. And so they were able to weave those political themes into the broader conversation. States that are successful also have a unified nursing community. That's one of the places that I think as a profession, the last 10 years, we've really turned the corner in being able to rally, have each other's backs, step out together when there is something that we're working on. It's also a place that we want to make sure that we talk to everybody. I'm sure you guys feel the pressure sometime at NAPNAP, being pediatric nurse practitioners, that FNPs like myself, we're the highest number of NPs out there. So we get into this rut of thinking everyone's practice looks like ours. What works for us is going to work for everyone. And we really need to make sure that we are expanding our view when we're running our campaigns, that we are thinking about, okay, what does this look like for the acute care NP? What does this look like for the rural NP who owns her own practice? Because for someone who is employed with a physician group, some of the tethers that are up in law, we're like, oh, that's not a big deal. I just stop out the hall and Dr. Smith signs something for me. This little hurdle is really not that big of a deal, but how does it impact everyone? The other part of the unified nursing community is other people see things that we don't. And so having everyone together, campaigning together, carrying the same message works, which brings me to the clear message and ask. Every state that has been successful has had a very clear message of what they are going for. That message and that ask in the ones that are successful really are rooted in what is beneficial for patients. How is what we are proposing going to how is what we are proposing going to improve the healthcare delivery system, save the state money, and do something for patients? Campaigns that talk about what it does specifically for NPs or the nursing community generally don't do as well, in part because our issues tend to be framed as battles between physicians and nurses, and nobody wants to get in the middle of a turf battle. So when we can expand that pool to talking about how it saves the state money or improves access, that type of messaging works. And the clear ask, legislators are a lot like nurse practitioners. You all know, you've had the patient, you go into the room, you introduce yourself, you're like, hey, what are you here for today? And the patient gets into this long, rambling message, and you're like, what? You just want to know when the patient comes in to say, I think I've got a urinary tract infection, I want an antibiotic. Even when they come in and they say, hey, I think I have the flu, I've had a sore throat since 8 o'clock, and you're like, it's 10:30, so 2.5 hours, and they want an antibiotic. You like the clear ask. And legislators are used to that too. People approach them every day, all the time, saying, hey, can you sponsor X to do Y? I want you to sign on to this piece of legislation. And so campaigns that clearly articulate, we want you to support this legislation to improve healthcare access by doing X, help legislators connect the dots. One of the things that I found in working with nursing is we're excellent at motivational interviewing. It's a phenomenal patient care tool to say, this patient is overweight and smokes. I know for their best health, getting them to quit smoking and losing weight will help them. And so we engage in motivational interviewing to help that patient get to a place where they are choosing to engage in healthy behaviors and choosing the path forward for that. In policy, that doesn't work. When we bring problems to legislators and frame things in that initial motivational interviewing, they will say, oh, there's a problem. I see what you're talking about. And they will propose solutions that don't always work for us. And so making sure our ask is clear ensures that when we're talking about there's an access to care issue, means we are saying, and nurse practitioners can fill it by you doing X. Otherwise, they might say, oh, let's spend more money on physician recruitment. Let's build a new medical school. All are valid solutions, and we probably need all of the above to move our country forward, but really being specific of what our ask is makes a difference. An active grassroots network, and I've been so impressed by the grassroots network that you guys have cultivated at NAPNAP and rallying around issues both on the federal and the state level. When I was in Colorado, the first legislative campaign I worked on was a signature authority bill. It came about because nurse practitioners who'd been in practice for over a decade had been sharing with the State Nurses Association that there were certain forms that they couldn't sign for patients, that they needed to sign death certificates. And it was really spearheaded by nurse practitioners who'd been in rural and underserved areas. And I'd heard about it. And, you know, from my education as an NP, I knew, yep, this is something I needed to engage in. However, one day I was in the practice by myself. My collaborating physician was on the other side of the mountains, available by phone. And I saw a young kiddo with an asthma exacerbation who needed to have a nebulizer treatment at home. You guys all know where this story is going. My signature would not authorize a home nebulizer. And the home care agency would not accept a signature or a verbal order from her over the phone. They needed a real signature for her. So we came up with a plan about using some inhalers and what their fallback position would be. Later that night, yes, that kid ended up in the ER with an exacerbation and needed actually to be admitted. I was livid. One little glitch in our healthcare system, not recognizing a signature of a nurse practitioner who is legally authorized to order that treatment for a patient, caused that family to have incredible stress, caused a child a lot of trauma to be admitted to the hospital, and cost our healthcare system thousands of dollars because one piece of paper couldn't be signed by an NP. So I joined in that campaign. We ran the legislation, and that first year it was not successful. And so we met with the Autism Society, who had been very successful in running legislation. And they said, the secret we learned is you need to have at least 3 contacts with a legislator to start to influence their vote. And we mobilized the next year when we ran that legislation, and we asked that every NP and every nurse, because we were working with the Nurses Association, reach out to legislators, share their stories of the nebulizer, share their stories as patients, and encourage legislators to vote. When that bill came before the committee, they had several bills on the docket. I think we were the second or the third one up that day. The physicians testified first in opposition, and then we were going to testify in support. For over an hour, I listened to my physician colleagues, some that I actually worked with at the university, talk about the dangers of having signature recognition on by nurse practitioners on forms, and how they needed to maintain physician oversight and supervision. And so when it was my turn, I was the first up to testify for the nursing community. And I remember this day so vividly. I got up, I barely said my name, who I was representing, and why I was supporting the bill. And the committee chairman got up from his desk and he went over and started whispering in the ear of every committee member. Each committee member would nod and say yes. And he did that across the whole committee, came back and sat down. And he said, I'm sorry to stop you. Ms. Kopanos, it's clear that you're very passionate about this issue and that you've got things to say. But I've just pulled my colleagues, and we have over 23 things to look at today. And with your permission, we'd like to move on this bill. My heart stopped. I did not breathe. I had no idea what was going on, but thankfully, our association lobbyist was sitting right behind me, and she kicked my chair and she said, Tay, let them vote. I was still so stunned that Charlie had to kick my chair again and say, Tay, let them vote. And so with a really heavy heart, I just had to say, Chairman, that sounds fine. Go ahead and vote. And every single legislator on that committee voted yes to move our bill forward. It wasn't about anything that I had said that day. It wasn't about magic words. It wasn't about the 50 NPs who showed up in white coats that were standing at the edge of the at the committee room. It was because the grassroots network of over 600 nurse practitioners in the state of Colorado had reached out to their legislators to say, this is what I need. This is why I need it. And it will improve patient care and make life more efficient. So even after hearing ad nauseum from our physician colleagues about their perceived concerns of holding the ground and preventing nurse practitioners from treating the paperwork for the patients that they were already authorized to treat, the bill moved forward. Grassroots cannot be underestimated. And so if you're looking at where you want to build capital in a year, building capital for your grassroots is a great place to go. The other thing that we've seen states be successful on are effective counters and defense plans. And on the effective counter, the most effective counter is to know what your red lines are before you even introduce a piece of legislation. Every piece of legislation, you all have heard it, making legislation is like making sausage. You start out one way, other things get added, the mix gets changed. There's always going to be folks that come to you with compromise. Before you even introduce the bill, knowing what you're willing to agree on, what you're willing to compromise on, and what your red line is so important. Especially as you get into the heat of the legislative session, it is really tough. You've invested hours, you've invested sometimes tens of thousands, sometimes $100,000 on lobbying and investment on a piece of legislation. And someone says, hey, we would be willing to allow you to provide this service if you have 8 years or 10 years of a transition to practice. And it's really hard in those moments to really be objective. And so knowing where your red lines are is helpful. Also knowing where opposition messaging and where their places are coming from is really helpful. As I'd mentioned before, when I was talking about Massachusetts and highlighted Texas, talking about education, the year Texas was putting forward those education messages of NP education is insufficient. There aren't enough hours to their program. That fact sheet that we pulled together, that Aanp Yardstick of effective measurements of clinical outcomes in education, we spoke with our colleagues in North Dakota and we said, hey, we anticipate the physicians are going to come out hard on education. So we encourage you to get out in front of it, talk to legislators, tell them why comparing the two disciplines isn't the same. Talk about the foundation of undergraduate nursing preparation, not years in NP experience, but the fact that NPs come to their NP education as a licensed RN already, having completed a 4-year undergrad that is rich in sciences and direct hands-on patient care, that they are already educated in evaluating, managing patients, giving medications, and evaluating how those medications are affecting patients before they even start their NP program. And then that NP program builds on that knowledge to expand their diagnostic skill and capacity and improve their prescribing, and that their programs, while they are shorter than other health disciplines like physicians, they are targeted specifically to the population that they are going to prepare. And the example that we often use is you guys, as pediatric nurse practitioners. The entire PNP program is 100% devoted to the care of pediatric clients and their families. You are not learning how to care for the older man with BPH. You're not spending time in the ICU or the OR caring for adult skiers who've injured themselves. The entire time of your program is specifically tailored to the care of kids and their families. So unlike a pediatrician, and I value their education, but a huge chunk of their education was spent training them with knowledge and skills that have nothing to do with the pediatric clientele that they're going to be seeing moving forward. So that was an example of where we knew that messaging about, hey, NP education is inferior that the physician community was going to try and put forward, that we're able to get out in front of. And so by doing that, North Dakota nurse practitioners got in front of their legislators, said, this is what we're running. These are some of the myths that you may hear. Let's set the record straight before they come in. When the physician community started coming in and trying to disparage NP education, those legislators had already heard the facts from the NPs. And so they were not dissuaded from supporting that bill. And that same year, North Dakota went green with full practice authority. The other core element that we saw really well in North Dakota, we saw other states building this out, is really this broad coalition of champions and stakeholders. State after state, we see this. When Minnesota passed their full practice authority legislation, I remember tuning in and listening to the legislative floor debate. And there was a legislator who stood up and was fairly emotional, which was a little surprising to me. He said, this piece of legislation has been really emotional for me. I know we need to do better for healthcare here in Minnesota. There's lots of proposals and things that we need to do to move this forward. But this bill feels like someone is asking me, who do I love more, my mom or my dad? Because people are making me feel like I'm having to choose between nurses and physicians on this piece of legislation. That broad coalition of stakeholder support really changes the dynamic between it being a scope of practice, a perceived turf issue, to being something that these are services and skills that these nurse practitioners already provide in our state. We're just changing the authorization for them to continue to provide these services within our state without some of these bureaucratic barriers imposed upon them. And that stakeholder group then makes it about the Alzheimer's community, the behavioral health community, the rural community, and adding those stakeholders. The other time that really stands out to me, the stakeholder piece, was when West Virginia was moving their legislation. West Virginia, just FYI, they would be green on our map, except they are prohibited by state law from prescribing Schedule II medications. They don't require a physician agreement for any element of their practice. They just are prohibited from writing that class of medication. But when the year that they retired their collaborative agreement, I had a reporter who called me up and she said, Tay, I talked to you year after year about this legislation of this doctors versus nurses. And I wouldn't have called you and I wouldn't have done a piece on it this year, but I need you to explain something to me. And I'm like, oh, okay. Well, I'm glad to talk to you about NPs. And she said, I don't understand it. We have Americans for Prosperity and union workers down at the Capitol saying that we need this nurse practitioner bill. I have never seen those two elements ever come together and support a piece of legislation, but I have school teachers, mental health professionals, nurses, unions, Americans for Prosperity, AARP. I have all these people down at the Capitol. What does this mean? And it was really nice to be able to say, it's because nurse practitioners are going to be able to make a significant difference in the cost and access to healthcare, and every single one of those stakeholders will benefit. And so every single one of those has skin in the game in making this bill move. So as you're planning your legislation, I would really encourage you to engage in this pre-mortem. Take a look at these 6 factors and make sure that you have them as you're moving your campaigns forward. The other elements that I wanted to talk to you about as NAPNAP leaders, these are things that you already know, but I think these are fair to go over. Building capital. Even if you're not currently working on a piece of legislation, every year is an opportunity to build legislative capital. This year, we had a significant number of state legislators retire and a huge incoming class of freshman legislators around the country. You've probably already done it, but if you haven't, consider writing a letter or scheduling a meeting with these incoming legislators, even if you're not running legislation. And in fact, it's kind of nice to meet with people when you don't have a direct ask from them. It's sort of like the more you get to know people, it's easier when that patient comes in and says, yeah, well, for me as an family nurse practitioner, when the lady comes in and says, hey, Tay, I need an antibiotic, I have a UTI. Once I have that relationship, I'm like, okay, let's walk it through. But versus someone who's brand new to me, responding to an ask when you have a relationship is always easier. But get into their office, find places that you have mutual overlap and shared interests. So before you go to those visits with those legislators, I'd encourage you, if you haven't already, scout out their campaign form and their websites, because very often they will have something on their website that intersects with the interests of your group that you can say, hey, I noticed, on your website and throughout your campaign, you really spoke about the importance of childhood education. And as the nurse practitioner, the NAPNAP Nurse Practitioner Association that cares for kids, we find strong affinity with that. And we know that kids who are healthy and kids who have access to healthcare services perform better in education. And so we'd like to learn how we can support you in some of these efforts as you're down here at the Capitol. Again, not necessarily an ask, but saying, hey, we know who you are. 2, we're watching you. And 3, we think we have some aligned interests and we want to see where we can move our state forward in those areas. The other thing that I'd encourage you to do is watch the news cycle for places where you've got healthcare articles that would be of interest to legislators. Thankfully, AANP's press release for Massachusetts was picked up in Forbes and a couple of other places. I'll share it with Michelle and she can share it around with you guys. I think it's really great if you've got a relationship with a legislator and your state maybe isn't yet full practice authority, printing off that article and just putting on a short little note and sending it to a legislator saying, oh my gosh, did you see that a Democratic legislature and a Republican governor came together to improve healthcare access for their folks in Massachusetts? We have similar problems here in Kansas, Indiana. I really think we should have a conversation about how we can do something similar here and send it off. Again, it just underscores that what we're asking for is normalized and other states have done it. Again, I spoke to you before about making sure we're sharing our experience. As an NP and a healthcare policy person for AANP, I really believe that nurse practitioners serve at the intersection of healthcare policy and patient care. Nobody knows more about how healthcare law impacts the lives of our patients as we do. We live that out with them. So it's important to share your story with legislators, just like mine, with that kid with the inhaler who got sent to the ER and admitted because that's not the way to phrase it for a legislator, but simply because a piece of paper required a signature from a physician instead of someone already authorized, and that we needed to fix that by authorizing signatures. So when you share your experience and your stories and the challenges, again, propose the solutions so that they don't propose new solutions that would say, well, instead of recognizing your signature, let's make home health care agencies take the stamp of your collaborating or supervising physician. We want to lead them directly to the water that we want them to drink and that solution. And then again, look for opportunities wherever you can to really build the relationship and create new partnerships. For local NP organizations, I know time is at a premium. Many of our smaller state groups don't have their own lobbyists. And so being at the Capitol full time just isn't going to happen. But there's easy ways that you can build capital that don't take a lot of time or take a lot of money. And so I would encourage you to do a little SWOT analysis of your landscape. Who are some influential stakeholders that you would like to partner with that would be helpful for you when you're passing legislation, or that are working on policies that are important to pediatric and family health, and watch for their pieces of legislation and offer to provide letters of support. A simple letter of support with your letterhead on it goes a long way in building political capital. Angie Golden, you may remember her. She was our president at AANP a few years ago, and she told me the story of in Arizona, they were running a piece of legislation that one legislator just couldn't get behind and support. And so they were trying to brainstorm to figure out how can we build a relationship with this particular legislator. One year he was running actually a piece of legislation that would probably line up with NAPNAP really well. It was about providing more nutritious meals for kids in schools. And so they went to his office, they met with him and said, hey, we really align with you on this particular issue. And so we are providing a letter of support for your piece of legislation. So when you're testifying and talking to other people, you can say that the nurse practitioner organization believes in this and that this healthcare provider group supports your legislation. They didn't say in exchange for this. There was no quid pro quo in it. It was just about how do we build this relationship with this legislator. They had several conversations. They talked later at a different time about their piece of legislation. And on the day that their bill was going to be heard in committee, that legislator was there. And conveniently, a few minutes before the bill was up for vote, he had a call and had to step out of the legislative hearing room and wasn't there for the vote. He wasn't probably going to vote in favor of their bill, but because they cultivated the relationship and he understood what the bill was about, he was able to step out, give some quiet support, not take any flack from his other stakeholders or constituents related to that bill. And they generated support. The other thing is testifying on healthcare legislation that has nothing to do with nurse practitioners. Those of you who might have heard me speak before, you might have heard me compare nurse practitioners and nurses to churchgoers on Christmas and Easter. There's a segment of our population that only shows up to church on Christmas and Easter, and there's a segment of the nurse practitioner community that only shows up during elections and issues that impact us. And if we're going to inform healthcare policy, we cannot be I and E constituents only. So providing an opportunity to get in front of a legislator and testify, even if it's just one of your members, it doesn't necessarily need to be your leadership, but someone that maybe you're grooming for up and coming is helpful. A couple of years ago, there were several pieces of legislation. There were some on concussion care. There were some on tanning beds and prohibiting minors from using tanning beds unless they had a provider's note or a parent's note to do so. And so around the country, nurse practitioners showed up and testified on those pieces of legislation. They didn't push anything about scope of practice. They simply sat down and said, I'm a pediatric nurse practitioner in dermatology. Every day I see and diagnose skin cancer in people, and exposure to carcinogens and sun exposure from tanning beds when people are young and adolescents increases their cancer risk exponentially. So as a provider who sees, treats, diagnoses, and manages skin cancer, I encourage our state to move on this ounce of prevention and prohibit children and minors from engaging in the use of tanning salons. It did a couple of things. One, it raised the profile and awareness of the risk of tanning salons and skin cancer. It raised the profile of nurse practitioners as educated, qualified, and informed healthcare professionals who should be informing healthcare policy. And it created an opportunity to inform those legislators who weren't thinking about scope of practice to simply hear, I'm a nurse practitioner. I diagnose, I treat, and I prescribe. So the next time they encountered an NP, and maybe we were talking about scope of practice or signature authority, they already had in their mind, healthcare provider diagnoses, treats, and prescribes. They are already doing these things, and so their level of comfort was higher. So with that, I'm just going to conclude. I can't wait to hear from Dave Mason and then hear from you guys. But again, this was our quick whirlwind of how to run a successful campaign. And when you're not running a campaign, how can you build your political capital to ensure that your success down the road will be maintained? So thank you for the invitation.
Thank you, Tay. And before we take questions for Tay, I do want to hit on a few things that Tay mentioned. And the first being that Tay mentioned coalitions and building that grassroots support and stakeholder groups and whatnot. Several years ago, our NEP team, under the direction of past presidents Laura Searcy and Raji Kopalu, put together a coalition toolkit. And it was researched and put together in a very simple format. So to help our chapter leaders and our individual members figure out where and how they can build coalitions to advance legislation, because you need a lot of force behind the voice there. And so that has been going through an editorial process, updating information thanks to Kristen Hill, Gili, and Jessica Edgar of the Health Policy Committee. And we will be republishing that document this month. So look for that in a newsflash or Inside the Beltway in February. You'll have links to that. But again, that's a great tool that sort of piggybacks on with what Tay was saying. Also, just remember, we have our online advocacy center, nepnep.org/advocacy, into our advocacy center area. And you can actually use that online system to write your own letters to elected officials or to use our templated letters. And one of those is a very basic, I'm here as your pediatric healthcare resource. Again, it's not a big ask. We have calls to action throughout the year for those specific legislative asks, but this is just a pre-formatted letter just to introduce yourself to the elected officials, whether that's federal or state. And it doesn't require going through the mail system because, as you have probably heard, mail especially at the federal or federal level in Congress is very slow because that's go through various testing for anthrax and many other things these days. So using that online system is a much quicker way to reach your elected officials. And thirdly, on the Massachusetts thing, again, thank you, Tay, for starting off, because that's always great to start off with good news. And I know that we have a lot of different folks on the line tonight, but Tay is right. That was a 10-year in the making type of bill. And Mary Chesney will speak to the fact that Minnesota was many, many years in the making to get full practice authority. And I want to applaud member Julianne Neems-Walsh of NAPNAP, who was at that very first meeting where they crafted the very first sentences for that bill. And she is still a NAPNAP member. She has been advocating for all this time. And she was there just in the last couple weeks advocating for the bill that was passed. But at one point, Julianne said, we made it less about turf. And the bill took on, at one time it had a nickname that was really sort of about reducing barriers to patient access. And it really made it about the constituents and the healthcare in the state to improve the healthcare for the people, never really mentioning anything about full practice authority or nurse practitioners. It was really just about this, we're in it for the people, we're in it for the improved health outcomes and whatnot. So that's always a nice piece to spin as you're thinking about legislation. Don't make it a turf war. Don't you try maybe not to use full practice authority and to really use this reducing barriers language. And I think that's a lesson I learned from Tay several years ago. But thank you so much, Tay. I want to open up for questions for Tay, or if you have any questions about the resources I shared, feel free to unmute yourself or put your message in chat. Anyone?
While we're waiting, I will just quickly say, Michelle, thank you very much for mentioning not making it about us and not making it about FPA. Years ago, when I first came to AANP, the organization had used the term plenary authority, meaning general authorization. Nobody knew what that was. And so the association changed it to independent practice, which was a flair word for physicians, thinking that people would then practice in a vacuum, which is not the case. People continue to coordinate, consult, and refer, even in full practice authority states. And we are finding that FPA can carry some of that same baggage. So to your point, the more you can make it about the end recipient of the care, the better it is about, because truthfully, it's not about us. We want to be able to provide the care to our patients every day in any setting to the best of our ability. And when there are places in law that are prohibiting us from providing that care, we just want to get those barriers out of the way so that the patient gets what they need. And so huge take home message. So thank you, Michelle, for re-hitting on that.
Very good. Any questions for Tay? Alrighty. So if anyone has questions, you can always email them to healthpolicy@napnap and I can share them to Tay. Again, this will be recorded, so you can share this information with your colleagues. They can watch the recording.